Many times these are awkward moments, but not today, because I would like to ask each of you, if you can just summarize one single message that every participant can take home after this meeting. So I don't know, where should I start? Maybe I'll start with myself to offer you an opportunity to think about it, because I thought about this. I think that probably in terms of the SARS, thank you very much for also participating on Zoom, because I completely forgot that Professor Sankara is still with us, so thank you for that. So to summarize in one phrase or one key message that everybody can take home from my talk is that it's very reassuring that the virus, the SARS-CoV-2 virus, doesn't appear to affect significantly or really in any way follicular or oocyte in terms of integration, and neither the sperm and nor the embryo up to day 5. And I think that's reassuring in terms of clinical practice, although there appears to be that patients that had the disease will have lower quality oocytes, and also males will have altered semen analysis parameters. It's reassuring to know that we could continue providing treatment for the population during this pandemic times. So, Professor Fatemi, would you like to give your message?
That was more than one sentence, Edgar.
Yes, it's the...
So I'm going to take also more than one sentence. I think the important point of my talk was to be critical on the studies we read. Doesn't matter if it's published in the Bible of Medicine or in a low impact factor journal. I think it's important to have a look at materials and methods, specifically when we speak about luteal phase. We need to understand the window of implantation. We need to respect the basic physiology. And the topic of luteal phase, I think you have seen that we can personalize the luteal phase based on the patient's requirement. Specifically with an agonist triggering, we need to understand that there are patient-specific pattern of luteolysis, and it's not that one size fits all. That was the topic of my presentation today, and I think the same is going to be valid for tomorrow, where we're going to focus not on the luteal phase, but on individualization of the follicular phase.
So with regard to the frozen embryo transfer, which was my topic, it can be executed immediately after a fresh cycle or after a freeze-all cycle. So there is no need to wait or to delay the frozen embryo transfer cycle, which can be prepared in a natural cycle or in an artificially prepared frozen cycle. A natural cycle, let's always make the distinction between a true natural cycle and a modified natural cycle, but there is no need to abandon the artificially frozen embryo transfer cycle yet. Maybe we should try to find solutions to circumvent the possible obstetric complications.
Thank you.
Do you mind to share? I have a microphone, right? Sorry. Why not? My topic about the implantation failure, I think that the summary is that this is not a balanced equilibrium between the embryo and the endometrium. I think 90% is the embryo, and this is what data shows. 10% is the rest of it. Also to educate ourselves and educate our patients. That is not just by testing that we will find something, thrombophilias, immune testing, microbiome, you name it. There are a lot of things that we have to look on the sides, but the main driver of implantation is the embryo. A good embryo, a well-selected embryo will give you a baby at home. And of course, we cannot forget about the other parts, mainly the uterus. And it's also important to remember that not all the problems have an easy solution, but the main driver is the embryo. I think this is the main message.
And for my talk, the main point is I think that clinicians obviously have to be very aware of all the clinical challenges in fertility treatments, but it's also important to understand or to have a bit of connection with the economic side, because of course that determines access of patients to treatments. And a second point is that the focus of those who have been interested in economic evaluation so far have typically focused on a very narrow approach to it, and there's a very big gap in terms of understanding the overall cost effectiveness of artificial reproductive technologies.
So, as you know, my presentation was regarding the utility to use the genotype analysis to improve the performance of our stimulation. I think that despite it is coming from the most of cases from retrospective analysis, we have now enough evidence to move forward. So I think that it is time to think about adopt even the genotype analysis in order to increase the quality of our stimulation. So to integrate it with the most common used intrafollicle count or anti-Mullerian hormone.
Thank you. Professor Sunkara, your one, two, three phrases conclusion, please.
Yes, I will stick to you and 1, 2, 3. So my 1, 2, 3 phrases are that RCTs and real-world evidence are complementary. Usually the real-world evidence sets a hypothesis, generates a hypothesis, and RCTs usually, test for intervention based on that hypothesis, and they will either back or refute the hypothesis. And as Professor Fatemi said, it's very important that when we look at literature, read studies, that we critically evaluate the methods that are employed, whichever journal it is. And when it comes to observational studies or real-world data, we have to make sure that the necessary confounders are adjusted to and the results are appropriately interpreted. And the same applies to randomized controlled trials as well. When you look at a randomized controlled trial, I will not give any examples. There have been recent randomized controlled trials. If we have to see that if this applies to our setting and it is the design is appropriate to what clinical practice is. So that is my conclusion.
Thank you very much. Thank you. Can I ask the audience to interact with the panel? Anybody brave to stand up and ask a question? Oh, please.
I would like to ask Professor Velasco, because I cannot perform always embryo transfer of genetically assessed embryo, and when I have no clinical evidence from the talk with the couple, when should I perform genetic examination or immunological examination? Because if you interact with the couple, they ask you make an examination, do an examination. Yeah. Please, my neighbor has this examination. Can you make me also? Thank you.
That's a good point, because that's what we see probably on the next day you see your patients. You sit down with them and they compare to each other. And they go into patient forums, and why didn't you look for this and that, no? And we don't do routinely PGTA, we don't do it to everyone. We usually suggest to do it beyond 38 in advanced maternal age, and then in some indications like recurrent miscarriage, severe male factor, which could be controversial, I agree. But basically, if you have a couple with a good prognosis, let's say 34, 35, and you do a round of IVF, you transfer 2 or 3 blastocysts untested, and she still fails to implant, one of the reasons could be that even if she's young, she can have a lot of aneuploid embryos. And before doing PGTA, which is expensive, we run this battery of tests, and we do a 3D scan just to make sure that everything is fine. Sometimes the patients, because she wants to do a hysteroscopy, she demands for it, you could do it, or you could check for chronic endometritis, you can check sometimes the microbiota, but we are very reluctant to test it because it's influenced by so many things. We had a nice chat at lunchtime, and it's influenced by so many things, by diet, by a lot of things. So my suggestion would be that when you do at least 2 or 3 blastocyst transfer in a good prognosis couple that didn't implant, first thing you can check all of this battery of things that the patient sometimes needs to be done so they get this reassurance. And if everything is fine, then move on for PGTA. But not I mean, if it was non-invasive and if it was free, we would do it to everyone. But it's about 50% of the cost of the whole cycle. So not everyone gets a benefit from the test. Thank you.
Thank you, Professor Dog.
I would like to come back to the discussion we had earlier on HRT cycles, fat cycles, and the risks for obstetrical and neonatal risks. From what I heard, one of the main reasons that we stick still to largely HRT cycles is the convenience for the patient and for the center, which is obviously a very important consideration here. If you look at the evidence, it seems like natural cycle could be more attractive to prevent the risks that are associated with HRT. Then the question becomes, what are the ways that a natural cycle could become, let's say, less burdensome for the center and for the patient to be carried out? So the question is, are there other ways that you guys are considering to look at natural cycle that could reduce the number of monitorings or make monitoring less burdensome?
If I may answer this question, we do a lot of endocrine profiling for a natural cycle, but mostly this is for scientific purposes to describe a natural cycle. And we are in the process, in fact, to re-describe the natural cycle, what we have learned in the books in Sperov and so on from the 70s and 80s. Now, we know that there is a certain pattern of ovulation. So there is always the same pattern. The one pattern is your LH goes up. The other pattern is you have a drop of estradiol. So basically the first day of ovulation, LH goes up, estradiol up, progesterone low. And we have published that with Barbara Lawrence. The second day of ovulation, LH is still up, estradiol drops, and progesterone is still low. So there is still no exposure to progesterone. The third day of ovulation, what you see, LH is still up, starts to drop but is still elevated. You have a significant drop of estradiol, and you have an increase of progesterone. So this is basically what you're interested at. You want to capture that point. Now, many studies, what they have done, they have used these urine tests, which are not very expensive, but also not very reliable. They're not expensive, but not very reliable. But what you could do, you could try to combine in order to reduce the cost. You could calculate the patient's cycle. The only problem is, I have to be cautious what I'm going to say, women are very weird species, you know. When you ask them, what is your cycle length? They will tell you 28 days. Because they know they have to ovulate, 25% of them will not ovulate because they're stressed. So we need to put that in calculation. So imagine if the patient is telling you, look, my cycle is 28 days, you would say, okay, most probably she's going to initiate the LH rise day 13, day 14, but 75% will not. 75% will, but 25% will not. What you could do, you could see the patient somewhere between day 12 to day 13, 14, do a scan. Maybe she doesn't even have a dominant follicle. So you don't need to do a blood test or anything because there is no dominant follicle. But if there is a dominant follicle, you could ask the patient to do the urine sticks until you detect that there is an LH rise. And the moment there is an LH rise, or the day after, you just do one blood test, one simple blood test. So you don't need any blood test during the whole cycle except one. And with this blood test, you would know, are you in the process of having a drop of estradiol? And you look to your progesterone values. Did you reach the progesterone of 1.5, which is thought to be the point of ovulation exposure to progesterone? It means with one simple blood test and a couple of urine sticks, but the urine stick alone is not enough. And that's a mistake many have done in the past with the publications, putting only on the urine stick. The urine stick is just an indicator. You have 30% wrong results with the urine stick. But if you combine the urine stick with your ultrasound findings and your endocrine monitoring, only one, I think then you have enough to calculate your 0.0, because this is a time where the patient starts to be exposed to progesterone. And then, again, for the purpose of science, we measure progesterone on the day of transfer too, because we want to know what is the value that we have in a systemic circulation. But to answer your question and to simplify it, I think this is a way we could go forward.
But rather than bringing the natural cycle to a higher echelon, I would not abandon the frozen embryo transfer cycle, which is artificially prepared. First of all, we will never abandon completely, because how many of our patients have irregular cycles, are oligoamenorrheic, so we will still need it in such cases. The more south you go, the more PCOS patients you have, and so on. So that's one. Secondly, we are now in the stage, and we started around 1 year ago with this screening. So at 11 weeks of gestation, we are screening 3 different populations: oocyte acceptors, recurrent miscarriage, recurrent implantation failure patients, and PCOS patients. So we are evaluating the performance of the FMF, the Fetal Medicine Foundation PE preeclampsia screening tools, so ultrasound, biochemical parameters, and then we will see whether the story that I just presented you, the huge difference between natural cycle and artificial cycle, is also really a reality, because it's also a different population that we are studying. A patient or a woman having a normal natural cycle who is undergoing a FET and a FET cycle and a natural cycle is a completely different patient than a PCOS patient undergoing an artificial cycle. So let us put everything into perspective as well prior to draw such firm conclusions and bringing the HRT cycle to the garbage.
Maybe one minor comment to that point. I agree with you, but only partially. You know, there are enough studies today to look to the difference between HRT and natural cycle. Now, when we do an HRT cycle, we just supplement estradiol and progesterone. We agree on that. What does corpus luteum produce? Do you think corpus luteum produces only estradiol and progesterone? No. There is one thing which is missing, and it's relaxin. And there are enough data to demonstrate vascular endothelial growth factor, which the corpus luteum is producing, relaxin, which the corpus luteum is producing. This is missing in the HRT cycle. And we have enough data on that. So we know that many factors which the corpus luteum naturally has been designed to produce are missing. Now, what do these factors do? They have an impact on the vascularization, they have an impact on vasoconstriction, they have an impact on the contractibility of the blood vessels supplying the uterus, the endometrium, myometrium. So if you calculate 1 + 1, I think, yes, you are right, partially, but there will be something, because this preeclampsia is not only in natural cycle, it's also you have less in a stimulated cycle, because you still have corpora lutea producing this relaxin, producing these factors which are missing in the HRT cycle.
Maybe just to wrap it up, sorry, please.
No, I just wanted to insist on that we actually, let's be honest, why do we do HRT cycles? Because it's doctor friendly and lab friendly. It's not patient friendly. They have to take medication for 3 months. So natural cycle would be better for the patients. But, then probably it's not the best idea to have on a Sunday 25 transfers, because they ovulated at the same time. So we have to plan that, and we have to come to a balance here. And I think the evidence is, as you're saying, is on the same direction, but still, I'm not fully convinced. And I think like many of us in the room. So we are actually running a randomized trial. We need to include like 1,000 patients, and we have included about 400 already. HRT versus modified natural cycle with euploid blastocyst transfer, and we'll see. And if the evidence is so convincing, then we will keep the HRT, as you were saying, Christophe, for anovulatory patients, egg donation couples with no menses, for selected patients. But so far, we do, about 6,000 cycles. Out of that, 50% are frozen transfers. And we have to plan. We have to plan that activity.
Juancho, we do 100% frozen cycles.
Sí.
And the thing which is interesting, when you consider the window of implantation, it's not 1 day, it's 2 days. So you can dilute the patients over 2 days, also over the weekends, but we still have to learn a lot. I fully agree with you.
So from a practical perspective, there are a few dimensions, maybe just to wrap it up, because the question is, what do we do clinically to integrate more natural cycles into clinical practice for our audience? So we have not touched on the possibility to defer ovulation, and that is probably one aspect that we need to look at in the future. There are modest studies there looking, but I think that's a possibility where we could administer a medication that will delay by a day or two the endogenous LH surge and ovulation. That's one. Two, I think we totally ignore the population we're dealing with. You started saying that we have to segregate between women that can have natural cycle because they ovulate and women that cannot. So for those ones, there's no option but to do HRT cycles. And I think the third one is the innate risk of the population, which we never consider. We fail to acknowledge that the patients that need IVF are a completely different population than the ones that get pregnant after 6 months of trying, that get pregnant after 10 months of trying, because once you're 12 months trying, you're already at different risk for any disease into the child, and possibly you have a background risk in pregnancy anyway yourself as a female. So when that background will be adjusted for, maybe the findings of these studies that make us discuss why don't we do all natural cycles will change. So it's a complex scenario, I think, but I agree we need to accommodate women more and maybe to think more, natural cycle, you ovulate on your own, let's do a natural cycle and see. Thank you.
Yeah, but we lack knowledge here, right? We lack knowledge of the window of implantation. We tend to think it's limited and probably it's not that self-limited. And there is very little information on how to estimate the follicular growth. There's data there, but we don't use it that much. And we more or less guess, when the patient may ovulate and when can you do a modified natural cycle. But I think there is still room for improvement there.
Thank you. Professor Sunkara, by the way, if you want to intervene, you can always start speaking, please. I know it's a male-dominated stage here, but you're part of it.
Thank you. I don't want to intervene, but I would agree completely. Yes, there are certain majority of patients we could give a natural cycle FET, but as Christoph said, there are patients who are anovulatory and we would have to give HRT. And also, the way he's looking at the different cohorts whereby, the current studies are not differentiating between women who have PCOS and therefore are having HRT when we're comparing with natural cycles, and that could be something that is affecting the results. So we need more clear data and also know what the absolute risk is. Yes, there is an increase in risk. What is the absolute increase in risk? And should we be changing protocols and how far should we be changing?
Thank you. Just one question while I have you. There's one question from the audience online. It's great to see the potential of RWE. When do you think that we can see them integrated to a greater extent in our daily clinical practice?
I think we are integrating them to quite a significant extent in our daily practices. It is happening. And as I said, the real world data are usually hypothesis generating or, looking at associations. But when we come to interventions, it's usually the RCTs. And as I showed some examples, the real world evidence is corroborating with RCT evidence, and that's very good to see as well. So if it's conducted well, then they go hand in hand. And Dr. to add something to Professor Manco's comment about the baseline characteristics of women, infertility itself is a risk factor. As I showed in my slides, infertility, the study from the USA where it's looking at pregnancy outcomes in fertile, infertile, and IVF women, infertility itself is a risk factor. Yes. So we're all on the same page.
And I think we have a duty to stress this out to our patients. I think we many times pretend we can fix everything, but we can't fix their background, truly. Thank you. So one question for Professor Fatemi, how to define the proper moment when to stop luteal phase support, both in fresh and in frozen, in case of positive beta-HCG test?
So in fact, when you do in a fresh cycle, the reason we give luteal phase support is because we have a lack of LH activity. As you have seen, LH is suppressed. But the moment the patient is pregnant, obviously the early pregnancy is producing ACG, and that ACG is obviously much more potent than LH. So the moment you measure your ACG, let's say 10 days, 12 days after the transfer, that is more than enough to rescue the luteal phase. Now, if you will ask from which point onwards does an embryo which has implanted start producing ACG, because you transfer, let's say, blastocyst, day 5 or day 6, when does it implant and when does it start producing ACG? That has been studied actually in Nuremberg. Licht is the first author. When you transfer basically a blastocyst, approximately after 2 to 3 days, you start producing very, very low dose ACG. Is that enough to rescue luteal phase? Most probably that is very low and not enough, but approximately 10 to 12 days after the blastocyst transfer, if you have a positive ACG, you can stop the luteal phase in a fresh cycle. Now, when you speak about a natural cycle, the patient has their own corpus luteum, and in fact, the corpus luteum is going to take over the function of the luteal phase support. Now, HRT is a different story because you don't have a corpus luteum, and I think Christophe did a paper on HRT, when to stop. And, you know, as a routine, even when I was in Brussels, we were continuing giving it up to 10, 11, sometimes 12 weeks. But I think that's overshooting, and also that can be reduced earlier than what we do clinically today.
Thank you. There's a question from the audience.
Yeah.
Please.
I had one more question that I can't help but ask, because earlier there was a question about recurrent implantation failure and the tests that you do, because I literally just got an email from a patient yesterday who I sent to Evie because she's one of the few unlucky people that had 3 euploid transfers that didn't work. And she's exhausted. She just wants to do egg donation. And she was told by Evie, well, first you have to do the endometrio assay, and you have to do immunological testing. But she says, well, I just want to do egg donation. So the question is, they're telling her if she does egg donation, she might still fail to implant if she doesn't do the endometrio test and the immunological testing. So what's your take on that?
Send her to Abu Dhabi.
No egg donation in Abu Dhabi. No, first of all, she's not my patient. That I can tell. Because it depends very much on how you approach the case. Has she had any previous pregnancies? Because if she had a miscarriage, you don't need ERA anymore. Even if you believe in ERA, which is a different topic. So if you move to egg donation, this is because you think and you're fully convinced that the problem is within the embryo, and particularly in the oocyte. So she could be one of these 5-10% that they don't get pregnant with PGTA, of course. I wish we had 100% everywhere. And I don't think that all the extra tests are going to help for implantation. This is my message. But it depends on the patient. Many times, many times, the patients need information. They need to have more information. And just by doing another cycle, they're not convinced that this is going to change anything. They think if you do the same thing again, we're going to have the same outcome. And you know it's not, because you have a completely different embryo, 100% different. And this is what makes the second or the third round successful rather than the first. But sometimes they need to have some reassurance. And the way they get this reassurance is by making clear that she has no thrombophilia, she has no dysbiotic endometrium, she has no displacement of the window of implantation. I think none of us, or in the immense majority of patients, we don't need that information. But for them to be able to move on to the next cycle, sometimes they need this information. So as I mentioned before, this is not a must. I think it shouldn't be a must in the profile of tests that we have to do. It has to be a compromise with the couple, and every couple is different. Some patients really trust your thoughts and they just follow and let you guide them. Sometimes you have to share the decision with them and they want to be tested. Sometimes you tell them, listen, you don't need ERA, but they can say, I want to be tested because my nephew or my uncle or my friend got ERA and then she got pregnant. Okay, so it's not an easy decision.
Thank you. Maybe one more question? Yes, please.
Microphone, please.
Hello.
First of all, thank you for your presentation before. I would like to ask you if you have a woman that is quite young, so before than 35 years old, and experienced 3 failure of embryo transfer. Did you suggest PGT analysis for this kind of patients? And another question is about the adenomyosis, because the problem with the adenomyosis is it is very difficult to diagnose it, even using the ultrasound. Do you believe that there is a space for progesterone treatment instead of GnRH agonist? Because the GnRH agonist, I have some difficult experience, because sometimes the patients experience menopausal syndrome, so it's not very easy drugs to prescribe for the side effect. Thank you.
Thank you. Well, for the first question, good prognosis couple that fails to implant 2 or 3 times, I think embryo selection by PETA is a good alternative, especially to give you information, because sometimes you will find 100% of aneuploid embryos, and this happens even in young couples. Sometimes the efficiency of this couple in reproductive terms is not very good, which doesn't mean that all the embryos will be aneuploid, but if in one cycle all of them become aneuploid, they can be successful in a second one. However, if in 2 consecutive cycles you have 100% aneuploid embryos, we have never been successful in the third one. So that's something that could be informative. And again, it's not the only way forward, but for them it's quite reassuring to know that the embryo that you're selecting, at least 70% of the problems can be selected. Regarding adenomyosis, that's a much more difficult question because I think no one has a clear answer. I agree with you that diagnosis is becoming easier with the scanners, but still you have to open your eyes and focus on the uterus and look for these features, these 7 features of naphthalene. I think any of us can see them if we pay attention to it. And these lesions, we know they create inflammation, and as in endometriosis, you have some progesterone resistance. So it's not an easy topic to discuss how to treat. So what we try is to minimize the fluctuations in hormones, the monthly menstruations. We try to reduce the inflammation, and this is what you can do with this GnRH agonist. And if the tolerance of the patient is not too good or is really uncomfortable, you can give a low dose estrogen. So you try to balance between 0 estrogens and fluctuating levels, try to minimize this, but still, we were discussing again this morning, maybe there's a couple trials showing a beneficial effect of this suppression prior to the transfer, but I don't think we have an answer for that. I think we need to focus on new drugs that probably will become available in the future, who knows, and that will be able to target specifically the pathways that these lesions within the endometrium may make, because so far some of these women end up in surrogacy because they will never have a baby. There's plenty of data, especially from Bercellini in Milano, the group with Dado Somigliana, and they have published extensively on the topic, and they show that these women have lower implantation and higher miscarriage rate, and there's not many things that are so helpful.
Thank you. I understand there's one more question in the back, please.
Yes, my question is to Professor Luton. We've been talking extensively about natural FETs and HRT FETs, like those are the only 2 options for frozen embryo transfers. I'm speaking because in the unit I work in, we use a lot of stimulated FETs, where we almost stimulate these patients like they're going to have an egg collection, trigger them, no egg collection, and do a transfer 7 days later. It brings the practicality of a HRT FET in that you're able to schedule and avoid weekend work. And also it gives you lots of corpus luteums, higher progesterone levels, which overcomes many of the problems people have seen with the medicated HRT FETs. And I was wondering, is that something that any of you are looking at? Because in our practice, we found it very, very successful. And then also you've been talking about many of the variables that have been affecting your these studies. But I think one variable that hasn't been looked at in many of these studies is the human element, the clinician. Because in our units, where we have a lot of PGS embryos transferred, you do see the difference between certain consultants having lower success rate with euploid embryos of up to 30, 40%, and others up to 80, 90%. Are we missing something by not looking at the human element as a variable in the success rate of these FET protocols?
Thank you for that question. As you know, and there have been many publications confirming these findings, the window of implantation is based, I'm going to repeat myself, based on the hours of progesterone exposure. Now, there is a beautiful publication from Denmark. Klaus Eding Andersen is the leading author in that. The moment you stimulate a patient, what you just mentioned, when you stimulate a patient to create multifollicular development, and you trigger this patient, like you do for the planning, for the frozen cycles, they measured the progesterone levels after 12 hours. And they saw sky-high levels of progesterone 12 hours after the triggering. It means your endometrium is advanced because you're stimulating that patient. Now, we have done a study which we are in the process of publishing. We measured in a stimulated cycle 2 hours after the triggering the progesterone values, and they doubled. It means if your progesterone now is 0.7, 0.8, 2 hours after your triggering, it's 1.6. Meaning, immediately after your triggering, you start creating a secretory transformation of your endometrium. What does it mean? It means your endometrium is at least 34 to 35 hours advanced. And that has been published on many occasions. Now, if you have an embryo which is fastly developing, it's a good embryo, that will be synchronized with the endometrium and you have a good implantation rate and good pregnancy rate. But I'm going to urge you to read a paper from Bruce Shapiro from Las Vegas. It's a beautiful paper, and he describes exactly this, what you are saying now. If you have an embryo which is developing good, that will catch up with that endometrium and you will have good pregnancy rates. But if you have an embryo which the diameter is slower, it's developing slower, you will take away the chance of that embryo to implant. It means certain embryos will have a good chance of implanting, but some embryos will not. You can imagine the moment you stimulate a patient, you create a shorter runway for an embryo to land in. If you go for an HRT cycle or a natural cycle, you have much longer runway. It means you give more embryos to implant in the longer runway, but the stimulation reduces that runway. You create a shorter window of implantation.
But then also the other question is the variable of the skill of the clinician. Because it doesn't matter what you're doing with your preparation. Yes. If the person does not know how, their skills are not adequate for the transfer, whatever your preparation is going to be, however well you prepare that endometrium, whatever protocol you're going to follow, that's not you're going to get a patient not falling pregnant, and we're looking at other variables instead of also adjusting for the skill of the operator.
Yeah, we agree with that.
Absolutely.
It's an internal quality measurement to ensure that all your clinicians are appropriately trained before you allow them to take the responsibility of performing an embryo transfer. We agree with that. Thank you. Another question there?
Yes, I'm Tanya Miltic from Bulgaria. I'm embryologist and maybe not the right place to be here. But in fact, I was part also from the PGT consortium. And so my comment and my question are maybe we talk about euploid embryos, but we know that mosaic embryos could implant also good as well as normal euploid embryos. And also there was in our PGT meeting, there were some centers who transfer aneuploid embryos, but not, of course, with trisomy, which are viable. And they get about 18 to 20% live birth rate without any karyotype abnormalities. So for me, the self-correction mechanisms of the embryos are not very well investigated. And we should concern very well which patient to go to PGT and which to not go. That's my opinion.
May I ask a question? What is the prevalence of real mosaicism? I'm not speaking about technical mosaicism, biological mosaicism. What would you say?
For me, it's about 50%.
50%. So I can tell you, Mina Popovic has a paper in press where they look to various clinics, the real mosaicism, and they compare different clinics. It goes between 2 to 30%, between 2 to 30%. So it means if you have a good lab, good biopsy technique, good genetic lab, the real mosaicism is between 2 to 3%. And then you need to distinguish, when you speak about self-correction, you need to distinguish between mitotic errors and meiotic errors. If you have a meiotic error, it's in the egg and it will not self-correct itself. If it's a mitotic error, yes, there is room for correction. And the more you go towards a blastocyst, or the later stage, the more you have these kind of corrections. So I think it comes back to the technicalities. This is why a group like Richard Scott's group they have 0 live birth if they have an abnormal embryo. Then you have the group in China, in New England, where they say it doesn't make a difference. So I think it comes back to the technicalities. To give you one very simple example. There is a study looking to the biopsy techniques. As an embryologist, if you have a blastocyst and you do a biopsy, there are apparently 2 biopsy techniques, where you take the laser and you cut with the laser through the trophectoderm in order to retrieve 5-6 cells. Now, the tip of the laser has 143 degrees. It means if you're using this laser through and through, what will happen? You will damage many cells surrounding your biopsy. It means you will have a lysis and damage many of the cells. Or you don't use this technique and you just cut the piece. And only this one small thing makes a significant difference in your level of mosaicism. You know, with your amplification, you can create mosaicism. With the platform, you know, I had no clue about these details, but we set up our own genetic lab, and I was astonished on every level you can make mistakes. And I think, again, here, the detail makes a difference. But if you look to publications between 2 to 30%, this is huge. This comes back to the same point with the clinicians doing transfers and having different results. I think these technicalities need also to be respected.
Thank you very much. Nice and clear. I think we need to finish. So there's a bit more work to be done, because the next slide will tell us what we have to do. So first, I'd like to thank the panel for their participation, very active participation today, the wealth of information they presented. We don't need to really sum up much because they did it themselves at the beginning of this panel. So thank you for your presence here.